Sir, please start in 3, 2, 1. We are live, sir.
Good evening and a warm welcome to everyone. For today's webinar, Oncology Cancer Treatment Updates 2023 for Journey in 2024. For today's session, I would like to invite Dr. Aditya Lance sir for his talk on molecular biomarkers. Dr. Aditya sir, please take away.
I think the screen sharing is not enabled.
Tech support, please.
Please share, sir.
I hope my slides are visible.
Yes, sir, it is visible.
So, good evening, everyone. Just giving you all a warm welcome. Before we start with the today's topic, that is molecular biomarkers in testing of lung cancer. So, the contents of my presentation would include the current lung cancer scenario in India, the biomarker testing in non-small cell lung cancer, evolution of biomarker testing in non-small cell lung cancer. First, we will review the past and then go for the current trends. And then there will be key takeaways. So the burden of lung cancer in India as per Globocon 2020, that lung cancer is the fourth most common cancer in India. It accounts for 5.5% of all the cancer incidences. And the total number of cases in the year 2020 was around 72,000. Which have in the Globocon data of 2022 now increased up to almost 82,000 cases per year. When we see the number of male patients in 2020, we realize that almost 8% of all the cancer diagnosis in males was lung cancer, and this is accounting for the second most common cancer in the males. When we look at the incidence, mortality of and prevalence of lung cancer, we already acknowledged that around 72,000 to 82,000 new cases are happening, out of which around 66 to 70,000 deaths are occurring due to lung cancer in each particular year. And the 5-year prevalence for all ages is around 80,800 lung cancer cases. Coming to a very busy slide, but enlightening one quite. That shows that around 50% of patients with advanced non-squamous, non-small cell lung cancer have a driver mutation that is targetable with a FDA-approved agent or a clinical trial. So just if you would focus that the blue area of this pie chart, around 31% patients have no oncogenic driver mutation that are detectable. Apart from that, majority of the patients, that is almost 2/3 of the patients, do have some or the other form of targetable mutations. And obviously, why this is important? Because studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy have improved outcomes, quite expectedly so. Then the guidelines recommend routine biomarker testing to guide the treatment decisions in advanced non-small cell lung cancer. Obviously, ASCO, that is the American Society of Clinical Oncology, states that we must test our patients for EGFR, ALK, ROS1, BRAF, MET exon 14 skipping mutations, RET gene fusions, NTRK gene fusions, KRAS mutations, as well as PDL1. So the ESMO and NCCN guidelines include additional biomarkers that could be tested based on the data that were not available in the CAP IASLC guidelines. So definitely we should stick with either NCCN or the ESMO or ASCO guidelines. Coming to the next slide. So what are the methods of tissue testing in non-small cell lung cancer? So first of all, we can do DNA sequencing or NGS or the polymerase chain reaction. Uh, it detects insertion, point mutations, and deletions. It detects aberrations of the EGFR, KRAS, BRAF, and HER2 along with MET. And single or full gene NGS panels are available. Then we can test RNA by RNA sequencing panels, which detect fusion abnormalities and are more sensitive for ALK, ROS1, RET, and NTRK. Apart from that, we can do immunohistochemistry or fluorescence in situ hybridization, which detects ALK, ROS1. They are highly specialized and can be faster. IHC obviously detects the ALK, ROS1 easily. It is easy, fast, and reliable. It can also be used to detect PDL1. Then evolution of the biomarker testing in non-small cell lung cancer, the past and the current trends. So obviously the tissue journey, when we see initially we were constricted to using tissue only, that would have been a resected specimen, an excised specimen, or small tissue biopsies via TrueCut. So further FFPE blocks could be made, and then tissue histopathology could be known. And if required, further DNA, RNA, or protein-based testing could be performed. Then we could also use cytology in the form of body fluids such as urine, ascitic fluid, FNAC, pleural fluid, sputum, CSF, etc. And obviously, these can be made into a block and further tested for DNA, RNA, and proteins. And now the newest trade in the block is the use of liquid biopsy from the blood and the cystic fluid. And these can obviously help us test for the DNA, RNA, and proteins in a non-invasive way. So the role of biopsy is to establish diagnosis, determine the histological subtype, and then perform the biomarker testing. The histological subtype, obviously, as we know, the squamous versus the non-squamous histology. For biomarker testing, primary tumors and metastatic lesions are equally suitable. Bone biopsy can be suboptimal due to decalcification and degradation of the DNA. Liquid biopsies, that is the cell-free DNA in plasma, are another option. Then testing for EGFR, ALK, ROS1, BRAF, V600E mutations, NTRK, RET, MET, exon 14 skipping mutation in all non-squamous non-small cell lung cancer. The use can be NGS can be used for testing to detect most mutation using least amount of tissue. So obviously NGS has some benefits. For squamous non-small cell lung cancer, consider testing in young patients who were never or light smokers, or if biopsy specimen is of a mixed histology. I must inform all my dear friends and colleagues today that light smokers, the definition has undergone quite a change from what it used to be in the current CDC guidelines of 2021. So apart from that, we can test for PDL1 expression in non-small cell lung cancer, and that would obviously help us in deciding whether or not the patient would benefit from addition of immunotherapy. The completion of testing should be usually within 10 to 14 working days of the biopsy. Then circulating tumor DNA testing has the potential to be applied across all stages of non-small cell lung cancer and throughout the treatment pathway, from diagnosis and treatment selection to monitoring the prognosis, response to treatment, and progression or relapse of the disease. Then circulating tumor DNA testing overcomes major issues and challenges associated with tissue testing, such as invasiveness, which can be quite a big issue for certain patients. And then obviously circulating tumor DNA in the bloodstream, which is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over the time. So circulating tumor DNA may never replace tissue biopsy entirely, but could have a complementary role to support the treatment selection in patients with non-small cell lung cancer. Then circulating tumor DNA may be used to detect MRD after surgery in a resectable disease. Obviously, this comes from TRACER X study, where the presence of MRD may be used to predict the disease recurrence. And detection of circulating tumor DNA in the plasma indicates the presence of residual tumor tissue, and it can be used to measure the MRD. And in the TRACER-X study, circulating tumor DNA profile was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by any standard imaging. Coming to the comparisons of tissue versus the liquid biopsy testing. So there are similarity and differences between the tumor tissue and liquid biopsy testing for molecular alterations. Obviously, coming to sample acquisitions, tissue testing requires invasive surgical procedures to obtain a tumor tissue, while blood or fluid can be drawn relatively non-invasively in the liquid biopsy testing. Repeat sampling, obviously, the serial testing is challenging with variable biopsy and patient risk, and liquid biopsy is minimally invasive procedure allowing for easy serial testing throughout the course of the therapy. Then biology, the correlation with histological and cellular phenotype is possible. The direct correlation between circulating tumor DNA results with the histology or the cell type is not possible and more reflective of tumor genomic landscape. Then in tumor tissue testing, the lower tumor content, cell content is acceptable with sensitive techniques, that is 1 to 10%, while for liquid biopsy, very sensitive methods are required as circulating tumor DNA may comprise less than 0.1% of the cell-free DNA. Uses then tumor tissue obviously uses existing validated tissue processing and handling procedures, while liquid biopsy utilizes standards for analytical performance characterized by circulating tumor DNA or cell-free DNA have not been very much established, and no guidelines exist currently regarding the recommended performance characteristics of these liquid biopsies. Then substantial evidence of initial targeted treatment selection and subsequent treatment after targeted tissue failure in advanced non-small cell lung cancer for tumor tissue, while for liquid biopsy, less but increasing evidence of initial targeted treatment selection and subsequent treatment after targeted treatment has failed. Then multiple genes are involved in non-small cell lung cancer as driver mutations can happen. So either we could go for single gene reflex testing or multiple gene testing as a panel by NGS. So obviously, why NGS is superior to single gene testing is that it has a number of advantages over single gene testing. As per the number of clinically actionable biomarkers are increased, the ability to evaluate all molecular alterations in a single test has given NGS a major advantages, which obviously help in decreasing the cost as well as the turnaround time. It is more so like it can be given like a similar analogy that NGS is like Hanumanji, because when we need to know what kind of targeted therapy we might use for a patient, the NGS actually brings the whole mountain here, and we are given with a range of options that can be performed cost effectively as well as quickly. Then the pros of using NGS versus single gene testings are that NGS detects a broad range of molecular alterations in a single sample and may identify new markers that could offer additional treatment options for the patient or provide information to help with development of new or more effective treatments. The downsides of using an NGS is that it has a highly complex workflow and requires experienced personnel for operation, and advancement in the field of NGS are evolving rapidly. Patients with the clinical community must receive sufficient education in this area, as we often find ourselves, not up to date with the current major scientific updates. Then obviously NGS is very helpful for testing for single nucleotide variant as well as copy number variants. We'll not go into the details of the molecular landscapes. Then coming to the EGFR mutation testing in lung adenocarcinoma, The sample types used for EGFR mutation testing can be FFPE blocks, fresh frozen or alcohol fixed specimens that can be used for PCR-based assays. The cytology samples are also suitable, so cell blocks are preferred over smears, definitely. Discordance between EGFR mutation status in primary tumors and corresponding metastatic sites are actually very rare. Then EGFR testing for early stage lung cancers, obviously with the coming ADURA trial now, and what my dear colleagues would be discussing in the subsequent topics of this CME. So now we should consider adding molecular testing for EGFR mutations to be performed on diagnostic biopsy or post-surgical resection specimen to ensure that EGFR mutation results are available for adjuvant treatment decisions for patients with stage 1B to 3A non-small cell lung cancer. Then, obviously, as we all know that both NGS and PCR can be used for detection of the EGFR mutations. What are the advantages of using NGS? So obviously there is one study that showed that 48.6% of EGFR exon 20 insertion mutations identified via next generation sequencing are missed by PCR. And out of 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified via PCR. So definitely NGS should be the test of choice for detecting any EGFR mutation. Coming to the ALK rearrangement, so in most cases, ALK IHC is 93 to 100% sensitive and specific when compared to fish. Obviously, false positivity rate of 0.1% is associated with testing by fish, but IHC is less expensive and hence it is more widely adopted. ROS testing, it can be performed via IHC and fish. Now, what the guidelines routinely recommend is actually if you are testing for ROS1 by IHC, you can reconfirm it by fish if it is positive. And if you are first of all testing ROS1 by fish, then you can reconfirm it by doing a IHC. And detection of elevated ROS1 protein levels by IHC may provide cost-effective screening prior to confirmatory fish testing. Coming to the KRAS testing, obviously, I think that there is the heading of the slide has actually been missed. So KRAS mutations are mutually exclusive with EGFR and ALK mutations and account for nearly 30% of lung adenocarcinoma. The most common of these arise in codon 12 and 13, with the G12C variant found in 13% of the patient with lung adenocarcinoma, predicting poor prognosis versus wild type KRAS. The method of detection can be either single gene testing or by multi-gene NGS panels. Obviously, sotorasib and adagrasib are now the targeted agents that are available and FDA approved for these mutations. BRAF testing, now BRAF V600E mutation is present in more than 50% of BRAF mutation lung cancers and is thought to be more prevalent in smokers. Non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in around 17% of the patients with BRAF mutation. Overall, BRAF mutations occur in 1 to 5% of patients with non-small cell lung cancer, most commonly adenocarcinoma. The testing can be performed by multi-gene NGS panels. And obviously now we are aware that the combination of dabrafenib and tremetinib is now available for V600E mutations. So in cancer, MET exon skipping protein mutations cause in-frame deletion of the juxtamembrane domain, resulting in increased stability and constitutive kinase activation. It is found to be present in 3 to 4% of non-squamous non-small cell lung cancer and 20 to 30% of the sarcomatoid cancers. The majority of the MET exon 14 skipping mutations can be detected with NGS, but increased sensitivity with RNA NGS has been found out. So MET exon 14 skipping mutation, we obviously know that DNA NGS can be used, but RNA NGS is more sensitive. Then testing for RET, that is the receptor tyrosine kinase, and RET fusions in non-small cell lung cancer. The normal role of RET is in neural urinary development. In cancer, RET gene rearrangement gives rise to chimeric cytosolic proteins with constitutive active RET kinase domain. It can be found in 1 to 2% of non-squamous non-small cell lung cancer and around 10 to 20% of the papillary thyroid carcinomas. The majority of RET fusions can be detected by DNA NGS, but increased sensitivity is found with RNA NGS. Obviously, RNA NGS has the benefit that obtain the fusion partner information without intron coverage issues and directly assess the fusion expression. While the downside of using a RNA NGS is that it is highly dependent upon the RNA quality, and poor quality leads to reduced sensitivity. Obviously, it has been considered as a test that is validated for RET testing, and majority of RET fusions can be detected with DNA NGS, but sensitivity increases with RNA NGS. Then testing for NTRK fusions, obviously RNA NGS has been found to be more sensitive for this also, and choice of assay will depend on the institution, the resources, and the clinical context. Reflex to NGS versus IHC is reasonable for non-small cell lung cancer due to low prevalence of NTRK, that is in the order of around 1%. So whenever we require NTRK testing, is the histologic tumor type known to harbor high recurrent NTRK fusion? If it is a yes, then we should go for FISH, RT-PCR, or RNA NGS. And if no, so then is there a sequence platform available? If not, then we use IHC as a screening tool. If no, and if yes, we use frontline NGS, preferably RNA NGS, and then IHC to confirm the protein expression in positive cases. Then coming to the methods for NTRK fusion detection. So we all know that the advantages of NGS is that it is potential for multiplex testing, less depletion of the available tissue, fusion partner and position are defined, and RNA NGS is obviously having a greater sensitivity for NTRK fusions. The disadvantage is that it has having a lower wait time for results, and the cost obviously increases when we are using RNA NGS. The choice of assay obviously will depend on the institution, resource, and clinical context now. Then coming to HER2 mutation testing in non-small cell lung cancer, it is present in around 3 to 5% of non-small cell lung adenocarcinoma, mostly exon 20 in-frame insertions, which are mutually exclusive with other mutations and mostly seen in never smokers. Obviously, this portends a worse overall survival than other subtypes of lung mutations. In non-small cell lung cancer, HER2 mutation and amplification must be identified using a NGF DNA panel similar to breast cancer. And IHC used to assess HER2 overexpression seen in 59% patients of the non-small cell lung cancer cases. Obviously, in 2022, the treatment paradigm for molecular biomarker test positive advanced non-small cell lung cancer has actually changed a lot, coming from the first generation EGFR inhibitors now to use of upfront third generation EGFR targeted therapy, and also the second and the third generation ALK inhibitors now coming into the play. The overall survival and the progression-free survival of these patients has actually tremendously improved. The maximum, obviously, as we know and are aware of, that ALK fusions can be associated with the overall survival of 7 to 7.5 years. So the treatment landscape has changed a lot. And last but not the least, coming to PDL1 overexpression. So PD-L1 clones the IHC platforms and the scoring systems for lung cancer. We know that for pembrolizumab, we are using 22C3, which is a platform by DACO, and it is a companion diagnostic type test with scoring of either PD-L1 positive or the PD-L1 high if the percentage is more than 50%. Then SP263 by Ventana, which is for durvalumab. SP142 for atezolizumab, again a platform by Ventana. And then for nivolumab, the 28.8 by DACO, which is a complementary test. Obviously, here is the PD-L1 testing using different antibodies. A different scoring system is adopted depending on the antibody used to detect PD-L1. And biomarkers for immunotherapy in non-small cell lung cancer, a controversial topic. Why? Because PD-L1 is the sole current biomarker able to guide immunotherapy. And imperfect PD-L1 negative tumors can still respond a bit, mostly when added to chemotherapy. So could this be a synergistic effect? We actually don't know, but the research is going on. TMB, formal marker for response, which is not currently used, and it has conflicting correlation with survival in the checkmate studies. Then MSI high or MMR tumors, it is not used or relevant in lung as it could be in the GI malignancies. And then LAG3, which is possibly related to resistance to immunotherapy, but is being studied currently. So in conclusion, biomarker testing for non-small cell lung cancer has evolved from single gene to multiplex testing, and multidisciplinary meetings can help in better understanding of sample and test requirements. The sample should contain adequate tumor content of at least 10% to prevent delay in processing, and ideal turnaround time is of around 10 to 14 working days. The high throughput platforms such as NGS can be used to screen several genes at a time and to provide results within the estimated TAT. And oncogene targets and testing methodologies, the clinical guidance strongly recommend broad molecular profiling to identify rare driver mutations for which effective drugs may be available, or to appropriately counsel patients about available clinical trials. And broad molecular profiling is a key component for the improvement of care in patients with non-small cell lung cancer. With that, I would like to thank you for your valuable attention. Thank you.
Thank you, sir, for this such an informative talk. For the next talk, I would like to invite Dr. Vikas Talreja, sir, for his talk on newer paradigm in resected EGFRM early lung cancer.
Thank you, Dr. Aditya, for a lovely talk. Thank you, Rishabh, for the kind introduction. And I wouldn't waste furthermore second. Dr. Aditya has given us a brilliant platform to set up on the stage as how we manage, especially the EGFR early lung cancer. So when we say an early lung cancer, it is either a new adjuvant situation or an adjuvant situation. Can I have my slides at the background? Yes. So we have two major studies which were presented this year with the phase 2 trial of neoadjuvant osimertinib in stage 1-3 EGFR positive lung cancers. Next slide, please. So as we know that neoadjuvant chemotherapy has been a standard of care for patients with EGFR mutation patients, and the percentage of the residual viable tumor cells after neoadjuvant is predictive of OS and DFS. So those who achieve a pathological CR or a less than 10% viable tumor cells have a greater overall survival as compared to those who haven't. And with 85 to 40% difference, that's huge, specifically in early lung cancer. Osimertinib has shown its efficacy in FLORA trials across the settings, and that's where this new adjuvant window of osimertinib was tried in an EGFR mutated non-small cell lung cancers. Next slide. So osimertinib was given, next slide, in twice daily dose for a month in those patients with possible resectable non-small cell lung cancer, stage 1 to 3A. it was a single-arm phase 2 trial just to see the efficacy. That's the primary endpoint. That was the major pathological response. That's less than 10% residual viable tumor cells. And since it had a power to detect around 50% of the patients having a major pathological response with an 87% power, the patient were not randomized just to see the feasibility of it. Two mutations, exon 19 and L858R, as the classical mutations were being considered. Next slide. Patients were equally balanced, and you could see 50% of them had 858R mutations, and 40% of them did have exon 19 deletions. And the median duration of neoadjuvant osimertinib was given for 56 days. Next slide. Next slide. So there was an equitable distribution between the stage 1 to stage 3. And if you could look at the response rate, out of the 27 patients who were given, 4 patients developed a major pathological response. The study did not meet its primary endpoint, that's major pathological response of 50%. It was achieved only in 15% of the patients. There was no significant difference in the major pathological response by the EGFR mutation subtype. There was no patient who had a pathological complete response, and a stable disease was seen in around 12 patients. Lymph node out staging among patients with positive lymph nodes with clinical and radiologically was seen in around 50% of these cases. And with the immature data right now, it is difficult to comment. Next slide. So we know that it is an efficacious drug, but does it has proved its mettle in a neoadjuvant situations? So far, so not so good. Next slide. If you could look at this complete surgical resections which was done, out of 27 patients, 24 patients could undergo surgical resections, and 1 patient developed progressive disease, and 3 patients were converted to CTRT due to unresectable. So these were those who were patients who were initially surgically resectable, but 90% of them could make to the surgery. 10% dropped out because of the various reasons during this trial window of 1 month of osimertinib. Next slide. And there were 10 patients who had 10% of the patients who had some form of grade 3, grade 4 side effects. And using a preclinical models, the RMB1 and the YP mutations were actively involved in the disease persistence. And as we know that RBM is that regulating the retinoblastoma protein, which causes the elevated BCL levels and tumor cell survival. And that's probably the downstream defective pathway, and that's where the pathological response was not observed. The YAP also was those mutations where the increased gene were identified, and that was also associated with not response to the osimertinib. Next slide. So to conclude, neoadjuvant osimertinib was not a good option. The study did not meet its primary endpoint. Small sample size, phase 2 trial, single drug study, no comparator arm, lots of YAP, RBM, 10 mutations. So possibly this could serve as a good purpose for the next few years. And that's where the osimertinib was disappointing in EGFR mutated non-small cell lung cancers. Next slide, please. Where it disappointed, there was a promise also. So ADAURA, as we had seen in beautiful last year, that adjuvant osimertinib showed that yes, there is an 83% reduction in the risk of recurrence with a hazard ratio of 0.17, which was never heard in oncology before. And in 600 plus 650 plus patients, you could see in stage 1B, 3A patients, there was 80% reduction in the risk of recurrence or death with osimertinib with a hazard ratio of 0.2. And that's where it is important that we also present the final results of it, the OS data of it. Next slide. Next slide. So everybody knows the osimertinib ADAURA trials. It's something which we all adore at the end of the day. Next slide. Next slide. So this is the overall survival, and with the hazard ratio of 0.549, meaning a 51 reduced chances of deaths, osimertinib has proved its mettle in stage 2 and stage 3 disease as a primary endpoint. And specifically, if you look at the 5-year survival rates, 73% patients were surviving in placebo arm and 85% of the patients were surviving in the osimertinib arm, showing that yes, this drug does work with 60 months of follow-up. This is promising. Next slide. Also, in all patients, the hazard ratio was similar, 0.49, 51% reduction in the risk of death when you give osimertinib. 78 versus 88% of the patients surviving in the osimertinib arm. Next slide. And if you look at the stages also, the larger the stage is, the greater the magnitude of benefit is. So 56% in the stage 1B. And if you look at the stage 3A, 63% of the patients, 63% there was the magnitude of benefit. So definitely all across the stages, the magnitude of benefit was there, but the higher the stage was, the larger the magnitude of benefit was there. Next slide, please. All those patients who have received a prior chemotherapy or a prior adjuvant radiation, the OS was maintained. Both showed there was a more than 50% reduction of the risk of deaths when you give adjuvant osimertinib, irrespective whether you have given the chemo or not. Next slide. All across subgroups, irrespective of sex, age, smoking history, race, stage, EGFR mutations, and adjuvant chemotherapy, all showed a overall survival advantage. Next slide. And if you look at the subsequent treatments also, which was a point of concern, 22% of the patients in osimertinib arm and 54% in the placebo arm had received more than one line of subsequent anti-cancer therapies. And the most common subsequent anti-cancer therapy was the EGFR TKIs. Very important for the discussion for the same. Next slide, please. And if you look at the safety summary, again, this shows that the drug is safe. No, not much grade 3, grade 4 side effects, a tolerable drug. Next slide. So to conclude, 51% reduction risk in the death in stage 2, 3A. Overall population, 51% reduction in the risk of death with an hazard ratio of 0.49. All across the benefits, subgroups, stage, regardless of adjuvant chemotherapy use, there was no new safety signals were identified. Clinically, statistically meaningful overall survival benefit across the subsets. Thank you for your patient listening. Would love to answer any questions if there are any.
Thank you, sir, for the wonderful talk. I guess there are no questions, so we'll move on. For the next talk, I would like to invite Dr. Sheikh Ejaz, sir, for his talk on real-world evidence, osimertinib in treatment in EGFR and NSCLC. Ejaz, sir?
Yes,
Sir, can you please begin your talk?
thankful to you for having today. As a matter of fact, um, just I have been assigned title of real world evidence, also as the EGFR mutated non-small cell lung cancer. Am I audible?
Yes, sir. Now you are audible, sir.
Okay, now I'm audible. So the real world evidence for osimertinib as standard of care in EGFR mutated non-small cell lung cancer. In the background, we know that EGFR mutations are present, and the PFS improves after treatment with EGFR TKIs compared to that of cytotoxic chemotherapy. And osimertinib, a third generation TKI, strong TKI, has a clinical meaningful improvement in the median progression-free survival of 18.9 months with a hazard ratio of 0.46 in the phase 3 FLORA trial. Overall survival was 38.6 months versus 31.8 months, and this gave us a basis and space for use of this drug in non-small cell lung cancer. The first report was the FLORA trial, and this was from an abstract presented at ESMO. And this trial showed that the drug had a double-blind study design, and this was the inclusion criteria were aged patients more than 18 with good performance status, and then expression of DEL19 or L858R mutated, and no prior anti-cancer treatment with EGFR or EGFR therapy, and there was stable CNS disease, and stratification was based on the mutation status, and as you see, 1:1 randomization followed by a RECIST criteria for evaluation. You see the baseline characteristics are almost matching, and then we see that good number of Asian patients and good number of smokers, non-smokers, and then patients in good performance status were included in the trial. And as we see the primary analysis of PFS, we see that the median survival of 18.9 months with osimertinib contrast to the competitor EGFR TKIs of 10.2. And if you see the forest chart, it always is favoring osimertinib use. Similarly, the overall analysis of the drug showed that osimertinib had an overall survival of 38.6 months compared to 31.8 months with the competitor EGFR TKI. So the conclusions were that that there was a statistical and meaningful clinical improvement in OS with using osimertinib, and median survival of the patients using osimertinib was extended to 6.8 months plus. Osimertinib in first-line TKI monotherapy to show statistically significant benefit, and after 3 years, 28% of patients osimertinib arm and 9% patients in competitor TKI arm remain on first-line treatment still. So osimertinib presented a favorable and consistent toxicity profile despite exposure. So the final overall survival of the FLORA trial explores the osimertinib as a standard of care for the first-line treatment in patients with EGFR mutated non-small cell lung cancer. We know that the NCCN guidelines also speak of patients who have got sensitizing EGFR mutations, and we see that category 1 evidence of use of osimertinib during the first-line therapy and upfront could be offered to the patients as of now. So in that, we have a real-world evidence and 3 studies which have been very much important and baseline for use of this drug in patients. And we have seen that all the 3 studies speak of the results which are favoring osimertinib use. As we already have alluded to that the use of osimertinib is good, and then survival benefit and overall survival benefit has been there with the drug, and it has been estimated that only 2 to 4% of patients with with cancer receive treatment with randomized controlled trials, raising the issue of representativeness. Well, that's another issue. Real-world data has become a useful tool to assess the unique insights into the routine oncology practice in a post-marketing setting. I think this is very important and thought-provoking for all the practicing oncologists that we have certain shortcomings in conducting trials in that manner. So we have seen that in the baseline, the key features were their median age was 68%, and brain metastases were present in 38% of patients, and most of the patients were in stage 4B disease. And the study had inclusion and exclusion criteria, as we see on the slide, and the study was thereafter proceeded to with the primary endpoints of MTTD measured from the osimertinib start to the discontinuation of therapy for any cause, A, and B, rate of treatment-related adverse effects, and rate of dose reduction and temporary or definitive treatment interruptions due to adverse effects. And secondary endpoints were median overall survival, median progression-free survival, overall response rates, and disease control rates. The primary assessment and effectiveness: patients with poor performance status, rare EGFR mutations, and active brain disease were excluded in the FLORA trial, and outcome of the patient was similar to the publishing data, thus adding consistency to the osimertinib therapy. And no differences in PFS, TTD, OS were noted in elderly patients and patients with comorbidity and less common EGFR mutations. As we know that median TTD discontinuation was around 25.3 months overall in this subset, but in patients who had MTD with or without symptoms, and we found that patients who do not have symptoms, their MTD had not reached as of now, but patients who were symptomatic and patients who had oligo metastasis, their median survivals were 18.8 months and 21.4 months respectively. So primary effective assessment of the disease: patients poor performance status, rare EGFR mutation, active brain disease excluded, and outcomes of the similar publishing data leading to the consistency of osimertinib therapy, and no treatment differences were noticed in the patients. Patients with poor, you have already this TTD appeared to be a more suitable endpoint to evaluate the treatment outcome in the pragmatic real world, and TTD was 25.3 months, as already alluded to. Then post-progression outcome analysis of FLORA 20.8 months, probably due to study population unfit for further treatment and different therapy for oligoprogressive disease. Better TTD was associated with fewer progressing sites and isolated progression compared to oligo or systemic progression of disease. And if we see the poor treatment outcome, and for patients with brain metastasis, presence of symptoms, and more than 3 metastasis diagnosis, suggesting that tumor load was a negative factor in the prognosis of these patients. And the same is depicted in this crowded slide. And so the primary assessment, after median follow-up of 12.3 months, PFS was 18.1 months, and MOS, median overall survival, was not reached at the time of the data cutoff, and CR was in 0%, PR was in 73%, stable disease was in 23%, and progression was in 4% of patients. And the same is seen in the this Kaplan-Meier survival curve, and showing that we have reached this. And this slide we already learned. So real-world diagnostic pathway, essential element of the evidence was based and could have helped a clinician for making a decision. Among the patients who were experiencing a progression of disease, there were about 47.257% who underwent rebiopsy at the progression, and tissue biopsy was obtained in 66.4% and liquid biopsy in 28.6%, and molecular analysis performed in 13 samples of 61.9%. There was draggable resistant mechanisms, including the MET amplification in 4, MET amplification with EGFR amplification in 1, and EGF amplification in 1, and HER2 expression in 1. So the data and safety conclusions regarding the use of this drug reveals that we had around 33.3% adverse effects overall, and the notable among them were uh, please bear with me for a while. There were skin and VTE, and we had about 9% of VTE among any grade, and then while we concluding the safety data, 110 patients, 87% patients experienced adverse effects, and 42 in all would mean 33% of grade 3 to 4 severity. VTE was most common in 7.9% patients. In real-world stress study, grade 3 pulmonary embolism was noticed in 2 pre-treated patients receiving osimertinib. My personal meager experience with the drug, I have yet to see and heard. I am yet to have seen patients developing a VTE under my care with this drug. So there was no difference in the rates of VTE reported according to age and performance status and morbidity and tumor load. So we this is the gist of it. And so in real world sequence studies, osimertinib confirmed effectiveness and safety of real world scenario in the treatment of these patients. The second study is the osimertinib as first line treatment in advanced EGFR receptor mutation positive non-small cell lung cancer, OSIFACT study. Same background with the use of osimertinib proving to be superior by virtue of the previous evidence, and the including and excluding criterion are shown. An advanced EGFR with a non-small cell lung with osimertinib as initial treatment, and the exclusion were patients currently using other anti-cancer drugs or undergoing thoracic radiotherapy and undergoing post-operative adjuvant chemotherapy or receiving osimertinib as second-line treatment. And the baseline criteria of these patients are depicted. And as we all see that median age of the patients was 71, and we had more females and in good performance status, and never smokers were 61.2%, with a histology of adenocarcinoma comprising of 98.2 and DEL19, L858R, and uncommon mutations accounted for 5.5. And we all have to realize that we had around 65% of patients with stage 4 disease and recurrence in 30% of patients. And we had a PD-L1 expression of more than 50%, 64, 1 to 49 in 31.1% of patients. And unknown was 26.6. Brain metastasis, symptomatic brain metastasis 6.1, and asymptomatic were 24.9. And the endpoints were PFS, and a secondary endpoint were OS, TTF, and response rates, safety, and post-treatment evaluation. So PFS events occurred in 182 of 538 patients, with median progression-free survival was 20.5 months, with 94% CI and in 18.6 not reached, as is seen in the diagram. But various factors which had bearing in the prognosis and were associated with PFS significance were the male gender, malignant effusions, liver metastasis, and advanced resectable disease. And with all respect to PD-L1 expression, median PFS was not reached in patients with TPS less than 1%, 14.7% with TPS less than 49%, 11.1 months with those of 50%, and not reached in patients with TPS unknown. So we see the efficacy, and we see the same thing in this slide showing male sex, malignant diffusions, and liver involvement, and PD-L1 expression as per the outcome of these patients and its significance. So indirectly would mean that patients who have got a advanced disease and poor performance status, male sex, and metastatic disease with PD-L1 expression would mean the management in a proper manner, so that we are aware that this patient is not going to do that extraordinary. Now, in the treatment discontinuation profile, we saw that the reasons for treatment discontinuation was in 219 patients, disease progression in 44.3%, pneumonitis in 25.6%, and other adverse effects of 16%, and patients who did not follow up was 14.2%. The adverse effects are noticed on the left-hand side of the diagram, and would be important to be known and kept in mind. The safety profile, we had pneumonitis of all grades was 12.8%, and grade 3 and grade 4 comprised of 4.5% and 0.7%, and grade 3 hematological toxicity was 4.3%, that meager, and then some QT interval prolongation in 4% of patients, and ejection fraction perhaps 1.5%, and all adverse effects leading to treatment discontinuation was of 16.9%. So we conclude that ORR was 76.2, and DCR was 94.1, and PFS was better in osimertinib than conventional EGFR TKI with respect to PD-L1 expression. Median TTF was 19.1 months. Median time from start of treatment to the onset of adverse effects was 56 days, although the range was from 5 days to 2 years almost. And pneumonitis of all grades occurred in 69% of patients, with grade 3 and higher in 4.5% of patients, and fatal pneumonitis in 0.7% of patients. So concluding that PFS was better in patients using osimertinib in real-world experience, showing its efficacy and favorable occurrence. And the discontinuation was because of side effects. Adverse effects was 18.8%, especially due to pneumonitis, which required better treatment and investigations. The other real-world evidence is the real-world study of EGFR mutated locally advanced metastatic non-small cell lung, with first-line treatment of osimertinib. And this study reports the demographic and clinical characteristics with RWTT-D and RWTT-D of patients with advanced EGFR NSCLC who received first-line and osimertinib in US. So the study design was a global observational prospective cohort using Europe, US, and Asia, and involved analysis of registry and electronic data from these countries. The US sub-analysis included the data from nationwide Flatron Health electronic system, and during the study period, de-identified data originated from approximately 28 US clinics, and for interim sub-analysis, data were collected through June 30th, 2020, and study is still ongoing and planned till June 2023. The inclusion criteria were patients of more than 18 years of age, advanced disease of stage 3B and 4, EGFR mutation documentation prior to the initiation of first-line osimertinib therapy, and initiated first-line osimertinib therapy was from April 2018 to March 2020. And the study design, as you see from time to time, has been of exclusion of patients by the criteria, and then patients identification window, and then follow-up of these patients in the time bar seen at the base of the design. So assessment and statistical data based on clinical and demographic characteristics, treatment patterns were summarized by Kaplan-Meier using to generate estimate of TTND and TTD. RWTTND was defined as the time for index from index date till the start of next systemic therapy or death in absence of next systemic treatment. RWTTD is the time from index date until the earliest and date of osimertinib associated with discontinuation on prior to the end of first-line therapy, and unadjusted and adjusted Cox proportion null hazards models were used to assess the associations between the baseline covariates and the clinical outcomes, and the index date for time to event analysis was defined as the date of first-line osimertinib treatment. And if you see the socio-demographic characteristics, and we see that median age of 70 years, and as usual, more of females, more whites, and 13% Asian population, and what we call other academic and community-based differences were there, and then the area from United States they were coming from was also noted. The clinical characteristics, as I said, that stage 3 up till 3A was in 89 patients, and 3B was in 5. Majority of them were 81.8% stage 4, and in six patients it was not recorded. Most of the patients were non-small cell, and then most of the patients had good performance status. There was history of smoking in 43.2% of patients, and there was no history of smoking in 56.8% of patients, and Charlson comorbidity index was seen as 0 index of 67%, and then more than 3 of 5.7%. Metastatic sites prior to index date, 0 to 1 in 46.3%, 2 to 3 in 41.6%, and more than 4 in 12%. Evidence of liver metastasis was seen in 14.4%, and it was not known or unknown in 85.6% of patients. And evidence of brain metastasis was in 33.6, and in 44.3 we do not, and we do not have in 22% unknown data. So EGFR mutations as were taken into consideration were common exon 19 del and L858R, and then exon 19 del plus the two together, and against the numbers shown in the mutations. And then if we see the treatment sequencing, there is lots of kinds of protocols they followed based on PD-L1 expression, then based on chemotherapy, then and clinical study based use using platinum, and then clinical study design breaks programs in 5, and then single agent chemotherapy and anti-VEGF treatment and others. And we saw at interim analysis around 58.0% of patients remained on first line treatment therapy or were lost to follow up, and in 18.8% of patients received second line treatment, including PD-L1 or PD-1, mono or combination therapies, and EGFR TKI monotherapy and combination therapy, and even platinum-based chemotherapy. 101, 18.4% died while on first-line treatment, and 4.7 discontinued the treatment. As we see the real-world time to the next treatment or death, a median follow-up of 9.6 months, with median RWTT-ND was 17.9 months, and the 18.4% people died, and in 18.8% we switched on to second line treatment. In the multivariate analysis, we see that the stage of disease, smoking status, Charlson morbidity index of more than 3, EGFR mutation type, and number of metastatic sites more than 4 bore prognostic implications, and the same is seen in the forest chart across. And then median RWTTD was 17.2 months, of which 18.4% patients died, and as we already said, that 18.8 switched to second line, and 4.7% discontinued the treatment. And we saw that this number. So what is the take-home message of the study? The study provides a real-world insight into the use of first-line osimertinib in the patients with advanced EGFR mutated non-small cell lung cancer as first data cut analysis of US population. The interim RWTT-ND and RWTTD results support the effectiveness of osimertinib in real-world population, and long-term outcomes will be evaluated on final analysis. So with this sort of exposition of the use and utility of this drug in the management of non-small cell lung cancer has been of great and immense help in the clinical practice. And I always express that the only thing which is coming in the way is the cost, because most of the patients' affordability becomes an issue, and then we've not been able to give this drug to the quantum and number of patients as we could have been doing with other TKIs. And I think my co-speakers and panel would support me in this. Thank you very much.
Thank you, sir, for the amazing talk. For the next talk, I would like to invite Dr. Rajat Shah, sir. Next session is sponsored by AstraZeneca, and sir will be speaking on reinventing adjuvant therapy in EGFR early lung cancer. Over to you, sir.
Thank you very much, Rishabh, and I thank the organizers for giving us all a chance and a open platform to discuss a very promising drug, that is osimertinib, which has been there and really living up to our expectations of a very robust EGFR inhibitor. So I would request the organizers if they could project the slides. Yes. Yeah. So the topic of discussion today is reinventing adjuvant therapy in EGFR metastatic EGFR mutant early lung cancer. So definitely the metastatic lung cancer has really been dominated by osimertinib, and with the FLORA trial and the FLORA 1 trial also documenting that the osimertinib is useful in combination with chemotherapy also. So now I will be discussing the role of osimertinib in adjuvant therapy of resected early lung cancers. Next slide, please. So we all know that there's a huge unmet need in the survival outcomes of a resected non-small cell lung cancer. The global 5-year overall survival data in resectable lung cancers in stage 1B, it is 65 to 70%. In stage 2, it is 50 to 70%. And in stage 3, it is 30 to 40%. So even after a complete surgery, we are not able to tell with confidence to our patients that, yes, you will be able to lead a cancer-free life. Next slide, please. So earlier we never used to do any biomarker testing in early lung cancers. We used to just project them up for surgery, and then we used to give them adjuvant chemotherapy for 4 cycles as per the ANITA trial which was there. So nowadays definitely there is a testing recommendations in early lung cancer, and we generally do EGFR and PD-L1 testing. And based on the EGFR mutations and the PD-L1 mutations, we generally try to have certain treatment recommendations, one of which we will be discussing right now. Next slide, please. Next slide. Okay. So now the prevalence of EGFR mutations in patients with resectable stage 1 to 3 non-squamous cell lung cancer. This is a result from an early NSCLC trial. In this trial, basically multi-center trial was there, and they collected the biomarker patterns in the resected adenocarcinomas. And here they found out that approximately 51% of the patients were EGFR mutant and 49% were EGFR non-mutant. And if we break up the 51% further down, so the majority were from the deletion 19 subtype, and the second most common was the L858R mutation. So this is in line with the prevalence which is there in the metastatic population also. What was a little surprising is the prevalence of the EGFR mutation was in the range of 51% of all adenocarcinomas. So that is slightly more than the national or the international average, but I think so this trial has projected such a high figure. Next slide, please. So so basically the EGFR means the patients, the results from the basically the treatment patterns has been that more than 2/3 of these patients undergo surgical resections, and only 46.3% of the patients receive some sort of an adjuvant systemic therapy. Next slide, please. So after the initial treatment, more than half of the patients with resectable NSCLCs experience recurrence within 5 years. So 40 to 50% patients remain cancer-free, and 50 to 60% patients recur. So there is a huge unmet need of developing good adjuvant treatments for these patients. Next slide, please. So this was the ANITA trial I had just mentioned earlier, which was the adjuvant chemotherapy after surgery for stage 1B to 3A NSCLC. And they gave chemotherapy versus observation, and the chemotherapy arm definitely was better than the observation. So cementing the role of chemotherapy in all cases of resectable lung cancers. Next slide, please. So EGFR TKIs likewise have also been tried in the adjuvant setting in the NSCLC settings, but somehow they have not translated into approval for a change in clinical practice. There has been the SELECT trial with Geftinib, RADIANT trial with Erlotinib, EVAN trial has been there, adjuvant CTNOG trial was there, BR19 trial was there. These are multi-country, multi-center trials, but somehow they have shown some of the trials have shown significant DFS benefit, but not translated into OS. Some of them have been negative trials, and hence overall the picture of using EGFR inhibitors in the adjuvant setting did not pick up any momentum. Next slide, please. So the current evidence for EGFR TKIs from all these randomized trials collated together in this forest plot suggested that there was an improved disease-free survival, but no significant overall survival benefit from if we pool this analysis from all the 5 trials mentioned earlier. Next slide, please. So why have these data not changed into clinical practices? Because the trials in date have been limited by design, size, and other factors. So there's no OS benefit, so it doesn't give us enough optimism to use these drugs. It is unclear if adjuvant EGFR TKIs is a therapy to push the patients toward cure, or just to kind of delay the treatment for metastatic setting. And there is no definite evidence or appropriate sequencing or drug for our there's no definite duration of treatment also which has been defined. Next slide, please. So with these limitations in mind, and with all these past trials, the ADAURA trial was designed. So the ADAURA trial took up all resectable lung cancers, adenocarcinoma stage 1 to 3 lung cancers with EGFR mutation positive on histopathological analysis. And they stratified the patients to osimertinib 80 milligram standard dose or placebo. It was a 1:1 randomization, and it was a planned treatment for 3 years. And basically the treatment was continued until disease recurrence or treatment completion, or 3 years, or discontinuation criteria were met. So next slide, please. The endpoints of this study, can we just go back? Yes, the endpoints of the study, which was as defined by the investigators, was disease-free survival. Yes, very natural, because all the trials are showing a disease-free survival. And the secondary endpoints was the disease-free survival in the overall population, and the landmark DFS rates, and the OS also was there. Next slide, please. So as we can see from this Kaplan-Meier curves, the DFS was improved, was very well in the primary as well as in the overall population, the stage 2, 3A, and in the overall population. So that was a very significant difference achieved by the use of osimertinib. Next slide, please. So adjuvant osimertinib significantly improved CNS disease-free survival also. So CNS mets, as we know, are very common in EGFR mutant population, and osimertinib, because it has got excellent brain permeability, so it somehow prevents the development of brain metastasis also, and therefore the CNS disease-free survival was nearing 100% in the ADAURA trial. Next slide, please. As far as the safety analysis is concerned, there was no new adverse event which was noted, and I would like to say that overall osimertinib, amongst all EGFR TKIs we have used so far across various indications, is one of the safest EGFR TKIs. Yes, it does have some diarrhea, it does have some mild rashes, but overall it is very safe as compared to the first generation and the second generation TKIs. Next slide, please. So the key takeaway points was, in order to improve survival, we need to put more efforts to identify lung cancers early. We should never miss an opportunity to test for actionable mutations. So hence, earlier we used to do it for metastatic settings, but now we generally do it for in the early lung cancer setting also. We definitely have to collaborate with our surgeons, with our radiation oncologists, and multidisciplinary team effort is definitely the key to improve survival. Next slide, please. So the patients may ask for treatment options for best survival probability, and we should definitely be ready and offer them as per the best available data. ADAURA data gives us the probability to remain cancer-free along with survival benefits. Being cancer-free is the goal of the patients as well as the treating physician. And next. With that, I would like to end my presentation, and I once again thank all the speakers, Dr. Sheikh, Dr. Talreja, Dr. Elhans, for an excellent deliberation on the topics which they have delivered. And I again thank the organizers also for choosing very good and pertinent practical topics for today's discussion. Thank you very much.
Thank you, sir, for the amazing talk. With this, we come to an end for today's webinar. Rajat, sir, would you like to say something at the end?
Yeah, as I had mentioned earlier, osimertinib definitely is proving to be a very versatile molecule in the sense that it is helping our non-small cell lung cancer patients in all settings possible, in the adjuvant setting, in the metastatic setting, first line, in the metastatic second line setting, as also in the metastatic setting in combination with chemotherapy. So, and in all the trials mentioned, it is definitely showing an improvement in the disease-free survival as well as the overall survival. So definitely a very robust molecule and a very easy molecule that way to give. In terms of side effects also, it is very well manageable, extremely well tolerated therapy. Another thing is the excellent brain permeability of this drug. So again, the scourge of CNS Mets in EGFR mutant patients is very well taken care of by this drug. Because this drug is so potent and so useful, definitely Dr. Elhans has already pointed out the importance of very reliable biomarker profiling of all the lung cancer patients. So earlier we used to definitely do separate EGFR, ALK, ROS, etc. But nowadays I like his way of putting that NGS testing is like the Hanuman, and they have brought out all the information possible within first few days of the diagnosis, and that gives us the clinician the confidence to use whichever biomarker, whichever targeted therapy they can use. So that is a very good analogy, and overall, with that, I would like to kind of end my presentation, and thank you and good night.
Thank you.
Good night, everyone.